and his fellowship in cardiology at the University of Miami. He's a member of the 19 physicians, actually not just a member, but a leader of a very large 19 cardiology group, which is really the core group at Baptist Hospital. And they're all very good. Actually, you can form a very large group, but in this particular case, every one of them are excellent cardiologists, and we're very lucky to have him on our staff. He's been on our staff for over 20 years. So, welcome, Dr. Fialkow.
The projector's off. Is that thanks again for having me back, guys. I have about 10, 12 minutes of slides, which I think will maybe bring some things together. But just let me explain a little bit why I'm here, what my message is. I kind of sit at a crossroads in medicine where I have lots of different responsibilities, lots of different experiences, and I think that brings me into a unique place. For example, I'm a clinical cardiologist. I don't do the procedures. I'm doing my scrubs today because I had to walk 3 dogs and get them ready. My mother was sleeping over. A car wouldn't start this morning, and I'm scrambling. But I don't do procedures. I don't spend time in the hospital waiting for the labs to be open and whatnot. I spend my day seeing patients. Also, I'm a board-certified lipidologist. That's a certification that the National Lipid Association started about 6 years ago, and I was one of its charter members, about 200 in the country so far. And as a lipidologist, you learn and you get experience understanding the real cause of vascular disease. Lipid abnormalities, which are fats, diabetes, these mechanistic approaches. In addition, I have a large clinical practice of patients, so I observe quite a bit, and I have leadership roles at Baptist Hospital and Baptist Cardiac and Vascular Institute, where I'm director of clinical cardiology. So what does that mean? Well, I see patients in the hospital, I see patients in my office, I have academic networking around the country with thought leaders, and as I sit in these positions, things started expanding in my mind, which actually led me to offer these services to my patients from a different spin. And a lot of it is stuff I'm going to bring to your attention that you're going to start seeing all over the place. Because really, we're developing a paradigm shift in our concepts of disease and health. Some of you remember, we were here about 1.5 years ago when I talked about the increasing obesity in the United States, the increasing diabetes rates in the United States, the lack of drop in heart disease despite statins and all these medical organizations. And part and parcel of that is, I believe, what we're telling people is wrong. What we're telling people to do to stay healthy is wrong. So now we have, at the tip of the ice, at the tip of the pyramid, if you will, are the people with significant vascular disease. These are the people that, to me, there's no better place than Baptist Cardiac and Vascular Institute. If you've got these wild blockages, this wild disease, we can fix these arteries in terms of opening blood flow. But we're not really fixing the underlying process. And that's what I'm working through Baptist and through my practice and through my partners to really educate people. Recognize you have a problem before it happens. And when I give talks to these groups, one of the things I encourage you is if you see even a coworker or a friend who might relate to some of this message, certainly incorporate them into your circle of influence. First slide. So we're going to talk, I said, top 10 things to remember to prevent heart disease. Obviously, it's hard in 10 minutes to go over 10 things to prevent the #1 killer in the United States. But let's go through a couple things. What is heart disease when we talk about this in the vernacular? Well, it's when the heart muscle is not getting enough blood. Blood carries nutrition, energy. Blood clears toxins. So if the heart muscle is not getting enough blood, this is heart disease. This is very important. It's chronic. You don't have normal arteries, and the next day you wake up with a heart attack. These things we're dealing with, these chronic diseases, if you think about all the things that as we get older we start worrying about, whether it's arthritis or gum disease or cancers or heart disease, stroke, and kidney failure, these things accumulate over years, over decades. So now we're offering the opportunity, let's find these things before they get to the point where you're actually symptomatic, before you have this event like a heart attack or stroke. A smoker doesn't smoke a cigarette and get lung cancer the next day. It's an accumulative effect. These are chronic diseases, and these are the scourge of our civilization because 120 years ago we were dying of infections and scarlet fever and things that we don't worry about because they've been eradicated. We're living past those infectious illnesses, and past accidents to some degree, although we can't prevent all those, getting to these chronic diseases. So atherosclerosis, that's okay, go back. Atherosclerosis is when the arteries become inflamed, irritated, and what happens is we used to think, and a lot of people still think this, if you get narrowing in an artery, it slowly accumulates. Next slide. It slowly accumulates. This is an abnormal artery. This artery should have been pretty big, but you can see it's filled with this, what we call plaque. The problem is we used to think these arteries slowly narrowed. So if you got to the point where it narrowed to the point where your heart muscle is not getting blood, you might get some chest discomfort. You'll go to the doctor. They'll evaluate you with whatever mechanism, and you'll get taken care of. The problem we now know is the non-severely narrowed arteries are the ones that rip and lead to a heart attack. So if I have a blockage in one branch that's 70%, and I have a blockage that's 30%, and I come in with a heart attack, statistically, it'll be the 30% blockage that causes the heart attack. What's happening? This is all, the area in the wall is all soft and mushy, and it rips the artery wall and a blood clot forms. So that's how you go from feeling okay to the next minute dead. Rip the artery, blood clot forms, no supply of blood to the heart muscle. We don't want to get to that point. We want to get to you when you're 30, 20, 10% blocked, not wait till you're 70% blocked. And the reason is you might skip a step, rupture the plaque, and have a heart attack. Scary statistic, and I remember saying this to the group before, 30% of the people in the United States with a heart problem, 30% will find out when they drop dead. So people who are sitting here at this table with blockages, don't know it, feel good, will keel over. Not a good statistic. So, I mean, I got to put don't smoking on there. This is still a major health problem. Interesting, do you know what demographic in the United States is the highest new smoking group? It's college women.
Wow.
College women. And they're not sure if it's because they think they keep their weight down or it's a social thing, but the number one demographic in the United States right now that's starting smoking are college-age women. Smoking is bad. Smoking has two toxicities. The smoke gets into your lungs where it's carcinogenic, it causes irritation, inflammation, chronic lung disease, emphysema. But nicotine is the addictive substance. And nicotine gets absorbed right through your cheeks and goes right to your brain before one molecule of smoke hits your lungs, which is why cigar smokers fool themselves when they say, well, I don't inhale. You don't have to inhale. The nicotine's getting right through your cheeks, which is why they like the cigars. Smokeless tobacco, same thing. Nicotine is the addictive substance, goes right to the brain, and nicotine is the substance that also causes the vascular disease. Smokers will die of heart attacks. If you're looking at a smoker and you want to predict their death, statistically it will not be lung cancer, it will not be lung disease, it will be a heart attack. So nicotine irritates the arteries, leads to that inflammatory process, and affects really the whole body. One of the thoughts of smoking, which is actually similar to one of the thoughts of diabetes, is ages the body. The cells prematurely age in response to smoking and nicotine. Next slide. So this is kind of the buzzwords, eat a healthy diet. And you know what? It pisses me off, pardon the expression, because I sit and I work, and this is not Baptist Hospital's fault, it's every hospital in the country, the American Heart Association, American Diabetic Association, they say, you know, eat healthy. What is healthy? How do we define healthy? You look at 3 newspaper articles, you're going to see different conflicting things. You go to 3 hospital academic centers, and they'll argue what's healthy. And this is the biggest scourge I feel right now, because we kind of know what's healthy from a scientific standpoint, from the lipid standpoint. But the message of what we're being told to eat healthy is wrong. Secondly, if you're an unhealthy person and you eat like a healthy person, it doesn't work. So in other words, to take a 300-pound diabetic hypertensive person and say, eat like this marathon runner, it's not going to work for them. Their metabolism's different, their response to food is different, and you know what? They're going to be starving, which is why most diets fail, is because we tell you not to eat enough for your body, and you're hungry. So what is a healthy diet? Well, fruits and vegetables we're not going to argue with. I mean, I always tell my patients, and I actually have my own philosophy towards this, which is to go as natural as possible, eat kind of how we evolved, and fruits and vegetables in their natural form are critical. So for example, an orange is a great fruit. You peel the skin. The pulp and fiber in the orange itself give you satiety. They don't let you absorb all the sugar, which is really a little bit of energy. Tons of fruits and vitamins and minerals in orange. There's no orange juice tree, okay? So when you're taking a glass of orange juice, you're taking the sugar of 4 or 5 oranges without the pulp and fiber, without all the healthy stuff. And that's an example of how the food industry, which can label, you know, incredible vitamins and healthy orange juice, it's killing us. It's poison. It's pure sugar. Take a glass of water, pour sugar in, add a vitamin pill, glass of orange juice. So really an example, now healthy people who are very active and whatnot, knock yourselves out, but if you're starting to gain weight, if you're a little bit pre-diabetic, if you have heart disease, this is an example. And I just got to share an anecdote. This is the first time I'm sharing this. I just shared it with Randy this morning. I was at West Kendall Hospital, which is a beautiful hospital, which is new in the Baptist system, where we have the cardiology services. And I was there 2 weeks ago, introducing myself to a new patient I was asked to see. 52-year-old guy. He had had 2 stents placed in his heart 10 years before, at the age of 42. Diabetic, high blood pressure, high cholesterol, and 12 medications. And as I'm there meeting him, he was being called in by the way, he wound up getting bypass surgery 3 days later, 52 years old. So the hospital was calling in what he wanted for breakfast. And this is not an indictment of the hospital. This is the American Diabetic Association diet. So I'm sitting with him, and I said, order eggs, order eggs. I can have eggs? Yeah, eggs are great. Pure eggs, no problem with that. Eggs are great. Order scrambled eggs. I said, if you want, you can have bacon. We can talk about that if you want, but actually it's fine. He said, they said, there's no way they're giving him bacon. I said, you know what, I'm not going to win that battle right now. Let that one go. He asked for a glass of orange juice. They said, you can't have orange juice, you're a diabetic. Then the next question was, what kind of toast do you want and what flavor jelly? So it's okay to give him a piece of white bread with grape jelly, but don't give him orange juice because it's got sugar. And remarkably, if you look at the diets of even the American Diabetic Association diet, the diets hospitals are giving, and they're just following, the medical organizations, it's incredibly contradictory and doesn't work. So going through, omega-3 containing foods, again, we could talk for hours about this, and I'm not going to bore you with it. Omega-3s are the healthier, all fats are kind of healthy. I'm not going to say healthy or unhealthy fats, but omega-3s, which come from plants, get converted in our body to useful kinds of fats. They are anti-inflammatory, antioxidants. So they seem to protect against a lot of these chronic disease states that we're dealing with, maybe even protect against some of the bad foods we eat. Are best sourced from fish. Let me just tell you that. Omega-3s come from plants. There's no animal on the planet that makes an omega-3 fatty acid. It's all from plants. But the body has to convert it into this form that's beneficial. And in the face of omega-6s, which also come from corn and soy and seed oils, and we just have too much of them, we don't convert them. So if you're eating flaxseed, it's pretty much, if you're a healthy runner, that's fine, but if you're looking to be healthier, flaxseed's a waste of time. Because that's the parent omega-3, we don't use it. You want to get a fish source of omega-3. The fish have eaten the algae, they've eaten the plankton, they've converted it into the active source. So when we get the omega-3s from a fish source, it's very healthy. Sugar, sugar, sugar. Next page, in case you don't remember. Next page. This page. Sugar is our enemy. It's amazing when you go back and look at the last 30, 40 years of our experience, right? What's bad for us? Fat. Wrong. These were assumptions. These were political. Since 1977, when George McGovern led a task force to tell us what to eat, which started out as an anti-sugar message, but politically turned into an anti-fat message. And we were told fat's bad for us. What has happened? You look at the rates of diabetes in the United States, it goes 1977 like this. You look at the rates of obesity, it goes 1977 like this. You look at the rate of fat intake, it goes like this. So we're eating 30% less fat as a country since 1977, yet we've never been heavier, diabetic, or more heart disease, or cancers. Why? It's not fat. And if you take fat out of the diet, what are you putting in its place? Carbohydrates. So let me just spend a minute explaining to you what sugar is so you can look at this a little bit more sophisticatedly. The food industry is allowed to label as sugar sucrose, cane sugar, the sweet stuff. To our body, carbohydrate is sugar. We as living organisms eat food. Food is digested to be absorbed as its basic elements. If you eat a Pop-Tart, you don't absorb Pop-Tart and have little Pop-Tart particles in your blood, right? So what happens is we eat food which are fats, proteins, and carbohydrates. Fats are digested and broken down into what are called fatty acids. These are absorbed into our body and delivered for energy. Proteins are broken down to amino acids. These are what's absorbed. And carbohydrates are broken down to sugar. So by the time it gets to the cells of your intestine, every carbohydrate is sugar. A glass of orange juice is sugar. Broccoli is sugar. A piece of bread is sugar. But the food industry only has to label sugar the sweet stuff. So I have patients say, I don't eat a lot of candy bars. What do you have for breakfast? Well, I have 2 pieces of toast, and well, that's sugar. Well, no, it's not. I don't put any jam in it. By the time it's in your body, it's sugar. Now, sugar has a whole different metabolism than fat and protein. The sugar triggers insulin, which causes the storage of energy, so we gain weight, causes hunger, causes this whole inflammatory response. Now, I just want to bring one more point to your attention, and I'll move through quickly because I don't want to bore you for the whole morning. There's something called cognitive dissonance. Okay? It's a great term I use all the time. And cognitive dissonance is when the brain gets 2 conflicting pieces of information. It can't handle it. So it changes one and extinguishes it to make it better. And the classic story of cognitive dissonance is in Aesop's fable, which is the wolf, the fox that's walking through the woods. He sees these sweet grapes on the tree. And he knows these are the incredible sweet grapes. He really wants them. He climbs and he tries and he can't get the grapes. So he's so frustrated that in his mind he says, you know what, they're probably sour. They're probably bad. So what just happened? First place, that's where the term sour grapes comes from. He couldn't get them. He couldn't handle in his mind that there are these incredible grapes and I can't get them. So he turned them into something that he didn't really want by making the grapes the problem. They were bad. Well, cognitive dissonance works like this. 30, 40 years ago, we noticed we were starting to get a little fatter. We started noticing the mechanism of heart disease was fat in the arteries. So the assumption was, well, geez, fat in the diet must lead to fat in the blood, which must lead to heart disease, which leads to death. So heart attack came from fat. These were all assumptions, by the way. There's still not one medical study that's showing fat in the diet leads to a heart attack. Not one. But these were the assumptions. But what else did we know? What does sugar in the diet lead to? Diabetes. What do diabetics die of? Heart attacks. So the same level of assumptions is sugar leads to heart attacks, it's got to be bad. But how can sugar lead to fat? That's the cognitive dissonance. Fat, we understand, fat leads to fat. Sugar doesn't, so they just eliminated the whole science of sugar being the cause of vascular disease. Well, we now know the mechanism. Insulin promotes the conversion of sugar into fat for storage. So the fat in our bellies and the fat in our arteries doesn't come from dietary fat, it comes from sugar. But that's an example of how 30, 40 years of medical research has gone down a road based on assumptions just because they couldn't even conceive of something that is the reality. Sugar is the enemy. Too much in our diet, too much worldwide. One of our big exports is obesity. China has the #1 rate prevalence of diabetes in the world right now. We always think of the Chinese as healthy diets and rice. Huge diabetic problem there. So I showed you the incidence of diabetes going up to the roof since the late 70s. Next. Let's move on. Body weight. This relates to diet. This relates to sugar. We know that overweight is important. BMI is the term you're going to be hearing more of now. BMI is body mass index. It's still not perfect, but at least incorporates height and body build. So for example, I have a person comes in who's 6'3", who says I'm 190 pounds. It says at the age of 40 I should be 170. I'm like, no, but that's for a 5'7" person. You're 6'3". So obviously we have to incorporate patients' heights as a difference. Overweight is 25, obese is 30. About 35% of the United States are obese. My BMI, and I'm a big guy, I just came back from a few days of debauchery since my kids are away with my wife eating like crazy. My BMI is 23. So you can imagine 30 is big, and we have 30% of our population is obese. Next. And this just shows you from an epidemic standpoint, what you're seeing is color-coded the states and the percent of population obese. That's BMI of 30, and you can see in 1990, we had less than 10 to 14%, and now 2009, we have states with over 30%, and that's just growing. So we're getting heavier, more obese across the country. Next slide. Next slide. This was the world's fattest man in the year 1896. This guy you would go to the Ringling Brothers Barnum Bailey Circus, you'd pay money to see the funny fat man. So this was the world's fattest man. This was something that was unique, and oh my God, can you imagine how a guy could be that fat? Next slide. Here was his competitor. Next. World's fattest woman. Next slide. And this is from Disney World from a couple of years ago I took. Next slide. Next slide. And the question then becomes, how much of this is willpower, which I would contend is not at all, and how much is genetics? We are genetically predisposed, individually, to put on weight, respond to different foods. You can't tell an unhealthy person to eat like a healthy person, like I said. It's not willpower, it's their metabolism, which is really the concept we're dealing with now. It's not how much we eat, it's what we do with energy. People with weight problems, the pre-diabetics, the hypertensive, atherosclerosis, they store energy. Other people burn it. And again, it's fascinating where this is going. But clearly, you can leave this slide, but clearly there's got to be a genetic component when you see two 700-pound brothers within 5 or 10 pounds of each other. Next slide. So this is an example of the metabolic problems of obesity. I just have 3 or 4 more slides, I think. This is what we call a metabolic cluster. And this is really what I'm doing in my practice is, you don't just see, okay, this person's hypertension, give him a pill. This person's got high cholesterol, give him a pill. Your sugar's up a little bit, eat less, lose weight, like it's so easy. Here's a pill. We're seeing these things related to each other. So if I'm starting to see 1 or 2 of these metabolic things which relate to each other, we start looking for the others. Sleep apnea is a big thing. You guys are probably hearing more about these sleep disturbances that happen as we get older, where we block off our airway and stop breathing, which leads to weight gain, which leads to diabetes, which leads to sleep apnea. You can see how these things are related. And this is basically a CAT scan. All that white is fat. And you can see it's not just in the belly, which is the middle, but it's all through the body. And you can see the different mechanisms of this. This is another one, non-alcoholic fatty liver disease. I'm pleading with the gastroenterologist. They have these patients who have fatty livers, is what it's called. And they keep putting them on low-fat diets. No, and it doesn't work. It's carbohydrates triggering insulin, depositing the fat in the liver. Put them on low-carb diets, the liver gets better. So just as an example. Next slide. So this is really a problem for our future. When you see those rates of diabetes going up, that's because we probably have a good 30, 40 million Americans right now who do not meet the diabetic category. But diabetes, as I said, doesn't happen overnight. It's a spectrum of problems where doing nothing, you eventually become diabetic. So we have these tens of millions of people that we know within the next 15, 20 years will cross that bridge to diabetes. What is the unique aspect of crossing the bridge? And again, this is kind of misunderstood. The issues of diabetes, again, carbohydrate intolerance, too much sugar, too much carbohydrate. The early stages lead to vascular disease, and that's again what we're doing. We're trying to pick up these people who say, doing nothing, you'll be diabetic in 8 to 10 years. We can fix that, but you have vascular disease. When you can no longer lower your sugar, because sugar's in the blood in a diabetic, sugar itself has toxicities. So when you're a pre-diabetic, to me, you have heart disease. We don't want to wait to say, well, now you're diabetic, you're at risk. In other words, the metabolism of what leads to diabetes promotes the heart disease risk. We want to get to people then. By the time they're diabetic, there are additional issues regarding the sugar out of control. You want to look at your waist circumference. It's not weight. It's not, so this incorporates the belly right over your hip bones. This is your waist. If you've got a lot of weight in your belly, both men and women, that denotes this kind of metabolism. We actually have a cool device in our office which you hold some bars, it looks at your body fat distribution, it tells you what segments it's in, and it's really just more, I mean, you can predict it, you can look at the person, but it's very provocative when the person says, holy cow, yeah, I see what you're talking about. Next. So that's how you kind of want to measure it. Go back, next slide. And obviously we want some improvements coming down. Next. A few couple of things. Reduce stress, yeah, easier said than done, right? We can't all just move to an island and sit where it is. But we do know that we do not pay attention towards stress release. We get up in the morning, our day is full, we go to sleep at night exhausted, and if we can find a few minutes to kind of decompress, it's actually been shown to lower blood pressure, decrease medication needs. It could be sitting listening to music in your office for a few minutes, it could be gardening, walking, taking the dog for a run. Again, 3 dogs in the morning with 1 puppy is not exactly stress release right now, I can attest to that. But we really don't pay attention to this, and I think you can start seeing a movement towards affording us that little bit of time to kind of decompress a little bit. Next slide. Sleep is really big. I mean, again, with my practice, my interest, a couple of years ago I started getting involved in sleep apnea and sleep medicine, and again, incredible how prevalent it is. I'd be surprised if anyone in this room would be able to get a full 6-7 hours of solid, uninterrupted sleep. And uninterrupted doesn't mean you're awake, but nothing that arouses your brain from the deep stages, which could be noise, could be sleep apnea. And we start looking at this, it's very prevalent, and inappropriate sleep leads to many of these chronic diseases. And a lot of it has to do with hormones and adrenaline and stuff that's happening to your body at night. But I want to bring one thing to your attention regarding sleep apnea, because I think it's, again, very provocative. So sleep apnea, which is very common, as you sleep at night, the muscles in the throat relax, you close off your airway, and you generate a higher pressure to pop your airway open. Leads to a whole slew of cardiovascular and other problems. But if a patient were if any of you were in my office, and I took your blood pressure and said, you're 200 over 100, come back in a couple of months, try and lose some weight, you'd walk out of the office saying, 200 over 100, this guy's the biggest quack in town, right? I mean, is that fair to say you would not want to walk out of your doctor's office with a blood pressure of 200? Well, when you have sleep apnea, the pressure in your heart is your blood pressure. The pressure outside the heart is the pressure the chest needs to expand. They've measured -60, -70 millimeters of mercury to pop that airway open. From your heart muscle standpoint, 140 in the middle, -60 on the outside, the pressure across your heart muscle is 200 millimeters of mercury. So an example of the kind of consequences of every night, 100 episodes a night, weeks, months, years of sleep apnea untreated is you're sleeping at night and your effective pressure to your heart is 200 millimeters of mercury. And we don't think in those terms because we're asleep, but it's the same exact physiology as if you're in my office with blood pressure 200. Next slide. So just to finish up, exercise is really important. Exercise does nothing for weight loss. I can explain all the reasons why. No one will be overweight, eating poorly, exercise, and lose weight. You have to change your diet. If you exercise and eat poorly, you're just going to keep storing the energy. You're going to get hungry and tired. Yet exercise is profoundly important. It helps our insulin sensitivity, so this diabetic process improves a little bit. Significantly decreases all vascular stuff. Interestingly, we're seeing a huge increase in significant joint